Hello, my name is Peter Lawrence, and I'm pleased to introduce the August edition of the Journal of Vascular Surgery, and to highlight 4 outstanding papers which are freely available for the next 2 months. Our editor's choice and CME article for this issue is entitled Epidemiology of Endovascular and Open Repair for Abdominal Aortic Aneurysms in the United States from 2004 to 14 and Implications for Screening by Danzi and co-authors. Screening for abdominal aortic aneurysms is only covered by Medicare for patients 65 to 75 years old with a family history of abdominal aortic aneurysm, and for men with a smoking history. The authors used the national inpatient sample from 2004 to 2015 to identify ruptured and intact AAA admissions and repairs, as well as the proportion of male smokers and all patients with family histories of aneurysms. Over 11 years, 65,125 patients were admitted for a ruptured AAA, and 461,194 repairs were performed in patients with intact aneurysms. 59% of the patients who underwent repair for a ruptured AAA did not meet criteria for screening. Patients who did not qualify were older in 63%, younger in 24%, and 36% were females who are not covered. EVAR use increased for ruptured AAAs from 10 to 55%, with an operative mortality of 35%, and an increase for intact abdominal aortic aneurysm repair from 45 to 83% over the period studied, with an operative mortality of 2%. The majority of patients who underwent repair for ruptured AAA do not currently qualify for screening and expansion criteria to include selected women, and a wider range of age should be considered. The next article, Fenestrated Branched Endovascular Aortic Repair, is a safe and effective option for octogenarians in treating complex aortic aneurysm compared with non-octogenarians, is by Mata and associate authors. They analyzed the outcomes of fenestrated branched endovascular repair, or FBVAR, in octogenarians. 195 octogenarians and 698 non-octogenarians were treated with FBVAR. Octogenarians had a slightly larger mean aneurysm diameter of 67 millimeters, as well as an increased mean number of visceral vessels, averaging 3.1, incorporated into the repair. Technical success was greater than 90% in both groups, and the 30-day mortality was 0.5% for octogenarians and 1.3% for the non-octogenarians. Major adverse events and freedom from secondary interventions at 3 years were similar. The authors concluded that FBVAR was safe and effective with nearly identical early outcomes in octogenarians. The next article, by Levin et al., the majority of major amputations after recessive endovascular balloon occlusion of the aorta are associated with pre-admission trauma. In this study, REBOA, which is a potential life-saving procedure, has had recent reports that have raised questions about its safety. The authors used the National Trauma Data Bank to assess 316 patients who underwent REBOA. Most patients had blood injuries with a high injury severity score. In 5%, there were major amputations above and below the knee. 11 were traumatic amputations. 71% were associated with ipsilateral vascular or orthopedic lower extremity injuries. Patients requiring amputation had more peripheral vascular procedures and compartment syndromes. Pre-hospital cardiac arrest, a decreased Glasgow Coma Scale score, an older age, and increased injury severity score were associated with a higher mortality. The majority of amputations in patients undergoing ROBOA were secondary to the initial traumatic mechanism. The final article by Nazi is entitled Impact of Impaired Ambulatory Capacity on the Outcomes of Peripheral Vascular Interventions Among Patients with Chronic Limb-Threatening Ischemia. Patients treated for CLTI in the Vascular Quality Initiative, or VQI, from 2016 to 19 were evaluated. Of 49,800 patients, 57% were ambulatory, 31% were ambulatory with assistance, 11% were wheelchair-bound, and 1% were bedridden. There was a twofold increase in 30-day death in patients who were only ambulatory with assistance or were wheelchair-bound, and a sixfold increase in bedridden patients. Among ambulatory patients, the risk of major amputation and death within 1 year were only 10 to 12%, while bedridden patients were 30 to 38%. Ambulatory impairment in patients with chronic limb-threatening ischemia is associated with a significant increase in 30-day mortality and a significant decrease in amputation-free survival after peripheral vascular intervention. Thank you for watching. For more information, please follow us on social media and remember to like, comment, and share. We hope you enjoy these 4 highlighted papers and the other excellent papers in this month's Journal of Vascular Surgery. Remember that these articles are free to read until the end of October. And thank you for your attention.